would like to call upon the stage Dr. Muhammad Sadiq Azim Sahab, MBBS, MD, DNB Cardiology, CCDS, IB, HRD. And now I would like to call upon the stage Dr. Muhammad Abdul Mujib Afzal, who is MBBS, MD, DM, Endocrinology. Now let us initiate the program with Tilawat al-Quran. But first of all, I would like to tell something about the Quran, which is the complete guidance for world humanity, which is most read book in the world and which is the most favorite book among all the people following the path of Prophet Muhammad sallallahu alaihi wasallam and the lovable religion of Allah subhanahu wa ta'ala. Allah tabarak wa ta'ala says in the Quran, "Inna ad-dina 'inda Allahi al-Islam." Indeed, before Allah subhanahu wa ta'ala, the favorite religion is Islam. And the book of Islam is many. But recently and after Prophet Muhammad sallallahu alaihi wasallam declared the Nabi, Quran Sharif became the final revelation. And this revelation is complete guidance and differentiates between the evil and the goodness and guides all humanity in all the spheres of the humanity, all spheres of the life. Allama Iqbal Sahab once said in a poetic way, वो मुअज़्ज़ज़ थे ज़माने में मुसलमान होकर, वो मुअज़्ज़ज़ थे ज़माने में मुसलमान होकर और हम खार हुए तारीक़ कुरान होकर। लिहाजा इस कुरान पाक की अहमियत का अंदाज़ा लगाते हुए कई सारे उलमाओं ने और हमारे अकाबिर और बुजुर्गों ने ख़ास तौर पर तलबा को तलक़ीन किया कि इससे जुड़ा रहे और अपना वाबस्ता और अपनी जो रिलेशन है, अपना जो रास्ता है, वो बना कर रखें। कहीं ऐसा न हो कि हम गुमराही की तरफ चला जाएं। तो आइए हम इसका पासो लिहाज करते हुए एक हदीस का, इसमें अल्लाह तबारक व तआला के रसूल सल्लल्लाहु अलैहि वसल्लम ने फरमाया कि हर वो काम जो अल्लाह तबारक व तआला के नाम के बिना शुरू किया जाता है, वो नाकाम और नाकाम क्या कहते हैं उसको, कामिल नहीं होता है। Each and everything which is initiated without the name of Allah subhanahu wa ta'ala is considered incomplete. So, I would like to call upon this stage the President of INSA, Dr. Mujibuddin Sahab, for the recitation of the Quran with the beautiful line of Allama Iqbal. तेरे ज़मीर पर जब तक न हो नुज़ूल किताब, तेरे ज़मीर पर जब तक न हो नुज़ूल किताब, गिरह गुशा है न राज़ी न साहिर कशा। डॉक्टर साहब स्टेज पे।
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله الذي أنزل على عبده الكتاب ولم يجعل له عوجا قيما لينذر بأسا شديدا من لدنه ويبشر المؤمنين الذين يعملون الصالحات أن لهم أجرا حسنا ماكثين فيه أبدا وينذر الذين قالوا اتخذ الله ولدا ما لهم به من علم ولا لآبائهم كبرت كلمة تخرج من أفواههم إن يقولون إلا كذبا فلعلك باخع نفسك على آثارهم إن لم يؤمنوا بهذا الحديث أسفا إنا جعلنا ما على الأرض زينة لها لنبلوهم أيهم أحسن عملا وإنا لجاعلون ما عليها صعيدا جرزا أم حسبت أن أصحاب الكهف والرقيم كانوا عجبا إذا أوى الفتية إلى الكهف فقالوا ربنا آتنا من لدنك رحمة وهيئ لنا من أمرنا رشدا. صدق الله.
Jazakallah sir for the beautiful recitation of the Quran. And now I would like to say there are two types of people in the world, or I should categorize the whole world in two categories, Jahil and Alim. And whosoever have knowledge is called Alim, and whosoever disrespects the Alim is Jahil. And now there is a current discussion, hot discussion on the salt. Few people say less consumption is fit for the health. Few agrees, no, it's okay if you have a nicer amount of salt, it will not impact our health. And few say moderate consumption of the salt will be okay for the health. Which point of view should be considered, and in what cases, on what factors? Age, sex, genders, etc. It depends. So, considering all these points, we should say one thing. According to the Quran, अगर आप किसी भी चीज से मुताबिक इल्म नहीं रखते हैं, तो आप उसके इल्म रखने वालों से राब्ता कायम कीजिए. फसअलू अहल ज़िक्र इन कुंतुम ला ताअलमून. Ask for the scholars who have the knowledge, if you don't know. Okay? And that's why a शायर said, हासिल किसी कामिल से ये पोशीदा हुनर कर, हासिल किसी कामिल से ये पोशीदा हुनर कर, कहते हैं कि इस शीशे को बना सकते हैं खारा. इसलिए जो आलिम होते हैं वो किसी भी टॉपिक से मुताल्लिक अपना इजहार ख्याल अपने हुनर और अपने इल्म की रोशनी में बेहतरीन करते हैं. लेकिन यही जब हम किसी अननॉलेजेबल पर्सन या इलिटरेट पर्सन की एडवाइस को मानने लगते हैं, हत्ता कि हमारी जान तो खतरे में होता ही है, माशरती एक खतरनाक वायरस से खतरनाक वायरस है इग्नोरेंस का. इसलिए एक शायर ने बहुत ही बेहतरीन अंदाज में कहा था कि यहाँ I'm sorry, I am not able to recite, but that is a very beautiful line. And that was, यहाँ तो हर शाख पे हम लोग बैठे हैं, अंजाम गुलिस्ता क्या होगा? I am forgetting the first line. So, basically, to enlighten the topic, salt debate, I would like to call upon the dais, Dr. Muhammad Sadiq Azim Sahab, who is MTBS, DNP Cardiology, CCTS, APHRE. Since he is a cardiologist, he may give us the best advice possible. And I would like to say one thing before he comes on the dais, please sir. In his honor, I would like to read the couples of Allama Iqbal Sahab. Nikah Buland Sukhan Nawaz Jampur Soz, yahi hai rakht safar mere karwan ki. Dr. Muhammad Sadiq Azam Sahab, thanks.
Thank you so much for your kind words. Thank you for today, Osama and Gary, everyone for having me here today. Kabir sir, thank you so much for inviting me. It's a very interesting topic today, salt and the heart. So before I start off, I'd just like to say, I'm just here to discuss the science. We are nobody to question the wisdom of our beloved Prophet, and if he has praised something, of course he knows much more than what you and I do. But it is prudent for us to also remember that our beloved Rasulullah hated excess. He asked us to do whatever we do in moderation, to stay away from excesses in all forms. is going to be the crux of my talk today. So, how low is low? Does it mean that salt is totally to be avoided? Has anyone tried eating food without salt? Trust me, it's not a very, it can be a form of torture in its own. As has likely been said, has been rightly said by many personalities through the ages, salt is a very, very important part of our diet, of everything that we do. You have, in fact, the origin of the word salt is starts from the Roman era, when it was called salt because the money was being given, the salary that was being paid to the Roman workers was so that they could purchase salt to put in their food. So that's where the word salary came from, and then that's how it is. And then this is a picture of the Satyagraha. I just put it there because we are discussing whether salt is the hero or the villain, pretty much like how it is being discussed whether Mahatma Gandhi was the hero or the villain in our history. And this is a picture from the famous salt satyagraha where the Britishers tried to put a hefty tax on salt just so that Indians cannot use it as a form of punishment, and that's where their downfall started from. So the role of sodium in health, all of us know sodium is a very, very important molecule. Kala is here from physiology. I think he can give you a much better thing, but I try to do justice to it as much as I can. So sodium plays a very important role in homeostasis. It's one of the most important extracellular ions, and if you have too much of it, it can be detrimental. But at the same time, if you have too little of it, it can also be detrimental. So it plays a very important role in maintaining the fluid balance, in maintaining your muscles, especially what happens when you go to the gym, when you do a marathon, when you run a long race, what do you do after that? You replenish yourself with electrolytes. Why is that important? Because sodium helps in muscle recovery, especially after exercise. It helps in maintaining structure and function of your cardiovascular system, of the nervous system, and very importantly, it maintains fluid balance. But sodium also plays a very important role in disease. When it crosses the levels of moderation, when it crosses the levels of its recommended homeostatic level in the body, what does it do? It causes hypertension, it causes heart failure, it causes various vascular stiffening, cardiovascular diseases, carotid diseases, strokes, it causes renal diseases. It also has a confounding event on the recently pandemic that we've come out of COVID-19. So by causing vascular damage, oxidative stress, it affects the hormonal milieu as well, and it has an effect on the immune system as well as on the gut microbiome. So what are the effects on the cardiovascular system? It has been found that irrespective of whether a person is hypertensive or not, taking an increased salt diet causes left ventricular hypertrophy. So a high salt diet in itself promotes left ventricular hypertrophy, which is a very important precursor for cardiovascular disease. Of course, it causes hypertension because it affects the total body water and the RAS cascade. It causes endothelial dysfunction because an increased salt intake decreases the bioavailability of nitric oxide, which limits endothelium-dependent vasodilatation, leading to endothelial dysfunction, which again becomes a very important precursor of future cardiovascular events. It increases vascular stiffness, which again eventually leads to hypertension. It leads to fluid retention and edema by virtue of increasing the total body water. There is something known as salt sensitivity. I mean, you might have come across people who say, "Arey bhai, kitna bhi namak kha lo, kuch bhi nahi hota." But in the same family, you will find somebody who says, "Doctor sahab, bachcho, itna sa namak khaye mera BP badh gaya." It is not that they are lying. Two people in the same family can eat the same dish. One person's blood pressure might go through the roof, the other person might be unaffected. That is because of something known as salt sensitivity. Each one of us has our own threshold to salt. Some people with just a minimum amount of exposure to salt can have disastrous effects on their body's homeostatic level, whereas others are able to tolerate a greater amount of salt than is normally considered normal. So what does this mean first? What it means is basically whether you are salt sensitive or salt resistant. It has been shown that when you restrict your dietary salt, you still have a benefit for overall cardiovascular health. So what do the guidelines say? End of the day, it's not what I say, what you say, what so anyone else says, but what does the data show? What do guidelines show? And that is what the debate is all about. Because we are living in a way we will question everything, where every thing which comes from the West is supposed to be bad, where we question the vaccine, we question whether COVID existed, we question whether statins are true or not, we question whether LDL is really bad, and then we land up with events and then we blame our own fate for it. Anyway, so now we are questioning the guidelines. So the guidelines say that you restrict salt to less than 2.3 grams per day for every month. And if you have cardiovascular disease, you tighten that control to less than 1.5. Now, is this too much? Do we have a leeway? Can we, maybe drag it a little bit more? Can we be a little more liberal with salt? Or is it just all humbug? We can take as much salt as we want. That's what we are here to discuss today. Now, before we go there, the average Indian diet contains close to 11 to 15 grams of salt. That becomes 5 times what the guidelines are recommending. Your average Chinese takeout, when you go to a Chinese restaurant, contains close to 7 to 8 grams of salt. One pack of medium French fries contains 6.5 grams of salt. So that is how much salt is present in our day-to-day foods. Sources of sodium in India, at least pre-pandemic, majority was dietary, that is cooking, home-based foods. A very small quantity was from processed foods. In the West, this was already the other way around. You can look over here, almost 70% of the sodium in the West comes from processed and canned foods. Only 10% comes from the food which they cook at home because they hardly do that. Today in India, probably we have very fast approached this, looking at the number of times we use our food delivery apps, number of times we eat outside. We are also taking in majority of our sodium from processed foods and minimum quantity probably from the food which we are actually cooking. The problem is processed foods contain extremely high amounts of sodium. A single burger will probably be containing 2.8 grams of sodium. I already told you a single pack of rice probably contains 6 grams of sodium. Even something like a soup, that's just an onion soup in a bread bowl that contains 2.5 grams of sodium. So that is over. Your dietary intake for your 24 hours is done in that one dish. So this is where you need to know where it's coming from, because unless you know where your sodium is coming in from, you will not know where to cut it out from. You will think, मैंने बस सूप ही तो किया, मैंने बस एक सैंडविच ही तो खाया, लेकिन वो एक सैंडविच में आपने कितना खाया? It's important to know that. Only then you will be able to know where you can cut it off. There is a new, whenever I counsel patients and I tell them that, reduce your dietary intake of salt. They say, नहीं sir, हम तो बस pink salt use करते हैं. We use only, Himalayan salt. हम बस healthy salt use करते हैं. So is pink salt really healthy? The answer is no. It is probably as healthy as your normal salt. Your table salt, white salt, pink salt, rock salt, they are all salt. They all contain sodium chloride. They are not sodium free. They have pink salt especially has the same amount of sodium chloride as your regular salt does. The reason it is pink is because in addition to your sodium chloride, it also has impurities in the form of potassium, magnesium, etc. which give it the pink color. Now people, manufacturers and they push it saying that you will get benefits of these micronutrients if you use pink salt instead of your regular good old white salt. And then they price it 3 times, 4 times the price of your regular white salt just because this is getting micronutrients. Be aware that if you want to get the benefit of those micronutrients, you would have to consume a lethal amount of sodium which is present to be able to get the amount of the micronutrients, because that is the amount, the minimum quantity in which those micronutrients are present in that pink salt. Okay, so don't be in this misconception. You may come to pink namak khana hai, you are fine. What about salt light? You all would have heard, no? Green packet Tata salt light. What is salt light? Is salt light a better alternative? Yes, probably it is, especially for people with heart failure, but not for people with renal diseases. Why is this? Because basically salt light replaces sodium chloride with potassium chloride. However, so it is not completely sodium free. It still has some amount of sodium in it. One other problem with it is it has a slight metallic aftertaste, so it might take some getting used to. But in people in whom they're not able to cut off the normal salt and they still want an alternative, provided the renal status is okay, provided they are not taking other drugs which retain potassium like mineralocorticoid, antagonist, etc., you can use this. There's been a study, which is known as the salt substitute and stroke study, which showed that using a salt substitute caused a reduction in stroke, major cardiovascular events, and all-cause mortality. So you have evidence to support its use as well. So salt and hypertension. Now this is what you are all familiar with, right? Namak hai, BP बढ़ता. Salt causes rise in blood. So multiple studies have demonstrated a relationship between dietary salt and blood pressure. A decrease in the daily intake of salt by 4 grams leads to a fall in your blood pressure by 4 to 6 millimeters of mercury, just by reducing your salt. Various cohort studies have demonstrated a 17% reduction in cardiovascular disease and a 17% higher risk of cardiovascular disease and a 23% higher risk of stroke with just a 5 grams daily higher dose of salt. So say for example, you just add 1 packet of french fries to your diet every day, you are increasing your risk of cardiovascular disease and stroke by close to 20%. Just by increasing 5 grams of salt in your diet, that's all. This was a big study done close to 2.5 years, known as the TONE study. Here they found that just reducing salt in hypertensive patients by 2 grams. So this is in patients who are non-hypertensive. In hypertensive patients, even a lesser amount in elderly hypertensive, after you take off their hypertensive medication, you just reduce their salt by 2 grams per day, their blood pressure decreases, cardiovascular events come down by 30%. So people who are probably on a single drug, very low dose antihypertensive, even if you take the antihypertensive off and just reduce their salt intake by 2.5 grams, you will reduce their event risk by close to 30%. That means 1 in 3 people who would have had a heart attack would not have it. High salt intake contributes to the development of resistant hypertension, and reducing salt reduces the risk of reduces blood pressure by close to 20 millimeters of mercury. So somebody whose blood pressure is not coming down below 160 will probably have a blood pressure at target of 140. This is something that probably is, considering that we are talking to predominantly a younger crowd here. If you have been taking more than 3 grams of salt per day, that means you are much more likely to develop hypertension going forward in life than somebody who has been taking less than 3 grams of salt per day. Now, this has been shown in the INTERSALT study, which was a study of 1,000 plus participants, which prospectively followed communities. And they found that in communities where the salt intake was less than 3 grams per day, the risk of developing hypertension with age was minimum. Whereas in those communities where there was a high salt intake per day, they had a higher chance of developing blood pressure with age. So if you don't want to develop blood pressure medicines, blood pressure, and you don't want to have to take BP tablets later on in life, you cut down on your salt from now itself. DASH is basically a dietary approach to stop hypertension. It has been around since 1992, and they found, the NIH, that is the National Institute of Health, found that incorporating a DASH diet brought down the blood pressure by close to 10 millimeters of mercury just by dietary intervention alone. You can see this was when the patient was taking 8 grams of salt. Blood pressure is close, is almost here plus 140, 150. At 6 grams, it has come down to 130, and at 4 grams, it is now down to 125. So probably this patient was not requiring any antihypertensive at all. Now over here, again you look at it, how the blood pressure has gone down just by reducing your salt intake. So basically, DASH diet reduced the blood pressure by 2 to 4 millimeters of mercury systolic and 3 to 5 millimeters of mercury diastolic. This is basically what a DASH diet comprises of. Basically, you take more of good carbs and avoid bad carbs. Good carbs are those which come from fresh salads. Bad carbs are those which come from fried stuff, processed foods, processed meats. You take fresh meats, you take white meat, chicken, fish, avoid red meat. You, avoid saturated things, avoid sweets. Take less than 5 servings per week of sweets, 2 to 3 servings per day of fats, 2 to 3 servings per day of low fat dairy, 2 to 5 servings per day of fruits, 4 to 5 servings per day of vegetables, and then 6 to 8 servings of whole grain. So basically, if this is your diet, you take 25% of lean protein, 50% of fruits and vegetables, and then 25% of whole grains. So this is how a DASH diet should be comprised of. So incorporating this diet alone will reduce your blood pressure by close to 6 to 10 millimeters of mercury. Now, salt in heart failure. Now, India is fast emerging as the heart failure capital of the world. In fact, 1.2 per thousand population in India are today heart failures, and these are the heart failures that you know. There are probably another million people who are living with heart failure but thinking that their symptoms are because of asthma or some respiratory problem or the other. That is what they think. So this is diagnosed heart failure. Okay, there will be much more than this undiagnosed in the community. Basically, salt involves the RAS cascade, and that leads to a worsening of your renin-angiotensin axis, and then salt fluid retention leading to heart failure. So the extracellular volume expands by almost 1.5 liters just by increasing dietary salt by 5 grams per day, which will precipitate heart failure. Now, even somebody whose ejection fraction is already on the lower side, even an increase in 500 ml of fluid volume can precipitate heart failure. Here, if you increase your dietary salt by 5 grams, you see extracellular volume goes up by close to 1.5 liters. Those of you who are in practice will know so many patients coming back, well compensated failures, they come back and then you ask them what happened, they say, nahi kitawat, main gaye the, thoda biryani kha liye, thoda salad chak liye. That, bas itne se itna ho jata, that's their question. You don't understand that bas itna is a big thing. Just one plate of biryani will probably be containing 2.5 grams of salt, depending on how much you eat it. So you have to know where your salt is coming from before you try to cut it out of your diet. It's very easy to say salt comes from. People think only the salt which they put into the food is counted. Your food itself contains its own salts. So you should know how much is the sodium content of what you are eating when you need to know how much you are consuming in 24 hours. Excess salt is harmful to both patients with heart failure with a reduced DF as well as heart failure with preserved DF. So, when the ejection fraction is more than or equal to 50%, it is considered as heart failure with a preserved DF. Less than 40% is known as heart failure with a reduced DF. Between 41 to 49 is mid-range DF. For all practical purposes, they work as the heart failure with a reduced DF population. So if your EF is fine, that is preserved. Now, most of the studies of heart failure have excluded patients with preserved EF. They are focused on patients with reduced EF, and they have found a definitive evidence that restricting salt is a mainstay in management. Now, these are two studies. One was the sodium HF study, and the other was the prohibit study. These were both long-term studies with good follow-ups of 6 to 12 months. And they both showed that there was a significant association between a sodium intake of less than 1.5 grams and improvement in both PNP levels and quality of life. In fact, the prohibit study also showed that compared to those taking 3 grams of salt per day, those taking 1.5 grams per day not only had a better quality of life, but they also had an improvement in their serum creatinine level, which was not seen in those taking 3 grams of salt per day. In heart failure and preserved EF, now this is one place where salt restriction has not shown conclusive benefit. That if you reduce salt to less than 1.5 grams in a preserved EF population, then there is going to be a benefit that cannot be said dogmatically. So this is still open for discussion because in most of the studies this subset has been excluded and this subset has just come into vogue. Even drugs wise we only have SGLT2 inhibitors that have shown a definitive benefit in this subset. Otherwise majority of the drugs, nothing that works in heart failure with reduced EF has shown a demonstrative benefit in heart failure with preserved EF, and even salt restriction is the case over here. So salt and overall health. Now, apart from cardiovascular health, increasing salt intake can also increase the risk of cerebrovascular strokes and dementia. It can increases the symptoms in chronic kidney disease as well as progression. It also affects the gut, where it has found increased intake of salty foods has had a link to development of gastric carcinoma. Even they say that there is an increased incidence of renal stones, osteoporosis, etc., and even obesity has been linked to this, because basically your salty foods, like for example you have French fries, you have burgers, you have pizzas, all of these not only are increased, they have a lot of salt, but then they also take their friends saturated fats and cholesterol and oils along with them, which ultimately leads on to obesity. So what's the problem? Why are we here discussing this? Why the whole debate? We have all the evidence. I've given you all the data. Problem here. Let's just stop and we'll go have nice biryani and sleep also. The problem is the data. Now this was a study that came in Lancet 2018, which said there's a paucity of robust high quality evidence to support or refute the use of reduced dietary salt. Then came this in Lancet which said that is this a second round of bad science? This was again in another journal, Medicina, which said that is salt not always a cardiovascular enemy? And then finally, the ESC came up with a statement saying that there is insufficient evidence to recommend a low sodium intake. Now, this is where the entire debate started from. So, what was the problem? I think the saturation is too much of this. Basically, this is a J curve. Okay, like in hypertension, they say that this is a J curve where from here to here is an essential electrolyte intake. Now, if you go on this side of the J or you go on this side of the J, that is, you take too much salt or you take too less salt, your disease risk will increase. So, high salt diet. So, ESC came out with a statement which said that high sodium intake more than 4.6 grams per day is associated with higher mortality and cardiovascular risk. However, no convincing evidence exists that a lower cardiovascular risk is there with a low sodium diet of less than 2.3 grams. So they said that moderate is good enough for heart failure patients also because of this J phenomenon. Now the ACC said there were a lot of other reviews. ACC did one, Nature did one, and they all came to the conclusion that there are two problems with this. One is all of these studies that focus on low sodium intake, where they said that if you are restricting sodium to less than 2.3 grams, you are increasing mortality. When they looked at the patients who had mortality, they found that they were all advanced heart failures. They were all end-stage heart failures. So I said there is a very present confounder over there, which can mean that the disease itself killed them and not the low salt. So you cannot dogmatically say that it was the low salt which actually caused mortality in that subgroup. The second problem they found was, they said that all of the studies which were done with this J curve were observational studies. None of them were randomized trials, none of them had the strength of evidence that is required to make such a statement. And this The major limitation was in all of these studies to measure the salt intake, they used something known as a single spot urine sample. Now, a single spot urine sample sodium excretion depends on many things. Depends on how much of fluid you are taking, depends on the status of your RAS, depends on whether you are taking drugs which are affecting your renin-angiotensin system. Now you know a patient with heart failure will already have an overactivated renin-angiotensin system, or he will be taking drugs which modulate that renin-angiotensin system, or he will be fluid restricted. So then in those subsets, this test is not reliable. So based on that, they said that this J curve is all bakwas. We don't stand by it. Our guidelines will remain the same. So the ACC/AHA, Nature, World Heart Federation still stick by the guidelines saying that 2.3 grams for general population, 1.5 grams and less for heart failure population. So they did this meta-analysis to prove that point, where they calculated the sodium intake based on different criteria. They used the Kawasaki score, an Intermat formula, another formula here, and all of the formulas gave a J curve. But when they looked at it with the gold standard test, which was a 24-hour excretion of the sodium, they found that the curve was now linear. That means the lower your salt, the lesser was the mortality. So using a gold standard test, they conclusively proved that even if you reduce your salt intake, you are going to reduce cardiovascular mortality in the heart failure, heart disease subset. So if you look at these curves again, patients from 2008 to 2011, as we have been making targets tighter, they say this, cholesterol, drug companies are pushing the use of statins. पहले तो 120 कोलेस्ट्रॉल को भी नॉर्मल बोलते थे, अभी तो 70 बोल रहे हैं, कल 50 बोल रहे हैं, उसके बाद तो 0 बोलेंगे. But what you don't realize is, look at the incidence of cardiovascular disease 10 years back. Look at the incidence of cardiovascular disease today. How many deaths due to MI were you able to prevent 10 years back? How many deaths due to MI you are able to prevent today? The benefit is enormous. You can see here, look at the target when it was liberal. Look at the cardiovascular mortality there. With the target of 1.5 and 2.3, look at the cardiovascular mortality today. It has significantly come down. Lives are being saved. Numbers will not lie. These are all the meta-analysis. These are all the this is the this is the odds ratio plot of various studies which were done right from 78 to 2011, and everything has favored salt restriction. So this is Nature review. Nature review again said the same thing, that the totality of evidence strongly supports a population-wide reduction in salt. Paradoxical J-shaped findings from studies with methodological problems should not derail action to reduce salt consumption. Every country should implement a strategy to reduce daily salt intake to the WHO target of 5 grams of salt or 2.3 grams of sodium. This action will result in major public health improvements. Now, what is the danger of table salt? I mean, you would have always heard, the doctors say, and I love to tell my patients, don't stop the salt which you put when you are cooking food. Just put enough salt so that you can taste in food. Don't put salt in food. There are patients, especially when the man of the house has a heart attack, he comes back for follow-up. He's often sitting with, his face is all scrunched up and frustrated, and he is very depressed, and his wife is sitting there and he's very insistent. He wants her to go out of the room so that he can vent his this thing. And I often ask him, what is the problem? Are you eating? इसे क्यों? उबला हुआ तरकारी दे रहे, बिना नमक की दाल दे रहे, गोश्त नहीं दे रहे, फूल के खिला रहे, इससे अच्छा में मर जाना. So it doesn't do this. This is torturing a person. Whatever salt you need to cook food, so that you are able to get a taste in it, you can use. Dietary salt is fine. Don't use table salt. Now the reason why we are so against table salt is this study. This study basically just probably proved what we've been doing for a long time. Basically what they did in this study was, they didn't bother about whatever dietary salt was being used. They looked at how much salt is being used on table. So they divided the patients into those who use salt always, those who use it usually, those who use it sometimes, those who never use on table. And they found that compared to the always using group, those who never or rarely use table salt, there was a 23 to 37% reduction in cardiovascular death, ischemic heart disease, and heart failure. Close to 30% reduction. And participants who combined a DASH style diet with the lowest frequency of adding salt had the lowest cardiovascular deaths. So too much of data. I'm sure everybody now just wants to know, okay, I have also got a slip saying that I need to conclude. So yeah, what to do? क्या करना है? ना हो गया, अब गए, अरे क्या बोलना? So what is the take home message? Now, you have to remember that salt and sodium are different things. When you say that the limit is 5 grams of salt, that doesn't mean 5 grams of sodium. 5 grams of salt is 2.3 grams of sodium. 5 to 11 grams of salt is 2.3 to 4.6 grams of sodium. 11.5 grams, 4.6 grams of sodium. So low sodium intake is taken as when you have a sodium of less than 2.3 grams per day or a salt of less than 5 grams per day. That is what we mean when we say low sodium diet. It doesn't mean zero. It doesn't mean नमक खाना ही नहीं. बिना नमक का खा के इतने जी मर जाना नहीं. नमक is good, लेकिन in moderation. So what are we trying to say? So basically low sodium मतलब how will you tell your patient to tell you 2.3 grams ही खाना देखो दूसरे डॉक्टर के पास जाएंगे इसको पूछने. How will you tell them? 1 teaspoon of salt in 24 hours is low sodium. 2 teaspoons of salt is moderate. More than 2 teaspoons of salt is high sodium. So what is our take home today? High sodium diet is bad. Nobody should be having a high sodium diet 100%. Should we be telling everybody to have a low sodium diet? Probably not. Moderate sodium diet is something which everybody should be having. Okay, that is 2.3 to 4.6. Fair enough. For people who are having heart disease, people with hypertension, probably people with renal disease, heart failure, you should be having a low sodium diet. And remember, I always tell patients this, you also should do that. Salt begets salt. The more salty foods you eat, the more you will crave salty foods. When you cut off salt, your first day, first week will be tough. But then you will start staying away from salt. You won't be able to tolerate a high intensity salts. But the beginning, the more you eat, you try eating fast foods every day. Those of us who have been in hospitals will know this. When you come home and you go and you eat outside, the next day again you want to eat outside. That's because salt begets salt. If you want, your taste buds want more salt. So most of the general population, moderate sodium intake is prudent. For those with established cardiovascular disease, a low sodium intake is recommended. So how do you restrict salt? This is my last slide. Best sodium, low sodium foods are these. You have to, probably go stage wise, week 1, week 2, week 3, you cut off salt gradually, cut off processed foods first, then you cut off your fried stuff, cut off table salt, and then you try to replace salt with other things like herbs, other condiments which add flavor. Salt is not the only thing which will add flavor to your food. Try to use other condiments. Learn how to read a nutrition label. Very often, we look at the nutrition label, there is calories there. But we don't realize the number of servings which that is mentioned for, the number of servings which are present in that entire pack. So one pack of chips might have 5 servings. But what is mentioned on the label is only for 1 serving. You will see that and think, hey, only 2 grams is, but it will actually have 10 grams. Alright, so you should know how to read the labels. So I hope I have been able to convince you that low salt is for good health and not for low health. If you are still convinced otherwise, you can keep a note of my number. Develop hypertension, you can come and see me. I won't say I told you so. Thank you.
Thank you, sir, for your insights. Now, I would like to call Dr. Muhammad Abdul Mujib Afzal sir, MBBS, MD, DM, Endocrinology, for the topic Low Salt, Low Health.
Assalamu alaikum. After listening to my friend and colleague, Dr. Sadiq sir, you might be wondering salt is harmful, but contrary to that, low salt is definitely harmful and moderate to higher intake of salt is good. Contrary to that, there are a lot of studies which support what I am going to say. So I will be dealing with salt, how it promotes it, how it is helpful to have more salt than what is prescribed by WHO and all. And I will try to be more logical because the contrary to what Sir said, my take is very different. Like very few people here might be knowing what I'm going to tell. And, it is going to be eye-opener for some of you and going to be shocking for some of you. There's so much data, but it is being considered. So we'll see why it is considered also. Okay. So a short disclaimer is just to find what is reality, what is the truth behind salt. Okay. So nothing, and some here a small heap of salt is there. So you can see there one side it is white and other side is grey. So when there is light, it will appear white. Otherwise, even whiter will appear grey. So and sometimes you need to have black and white together, side by side, to compare what is really white and what is really black. So salt is an essential nutrient, and sodium is an essential electrolyte which is required for numerous physiological processes. And it is tightly regulated. It is not salt which regulates us. We are not bag of salt water. If you add some salt water to us, it will increase our blood pressure. There are regulations, there are hormones which control that. And why in some of the people salt raises blood pressure, but not all the people. And why it is so, I will also be going to that. So salt is also very important for action potentials. We know the electrical system of our whole body, like from neurons, from the brain, from our heart. So all the nervous system which controls everything in our body is into action potential, and also some of the hormone secretions are also dependent on hormone secretions. So it is salt very important for hormone secretion as well as nervous system activity. So before going any further, we will see the history. History tells us that before there was refrigerators were invented, the average salt intake was very high, like 30 to 60 grams per day. That's because everything was preserved in salt. The only way food can be preserved was salt. And during those times, there was no food was not widely available. Like we have so many stores now, but during those times, even food was not easily available. So they used to store everything, like fermented vegetables, pickling, and everything. So their salt intake was much higher, 5 to 10 times higher than what we usually take. And the word salary, as Sir said, it is derived from salt because they used to pay as a salary to soldiers to salt. Even salt, soldiers, the word soldier is derived from salt. And even the word salad, because Greeks used to add salt to the salad. So the word salad also derived from salt. So the thing to be noted is there were other commodities, so many other commodities, grains and all. Why they used to give only salt? Because they know that salt is very essential for soldiers, very essential for their physical fitness, and very essential for their physical their physique and all. So we'll learn how salt will affect their physique and physical things. And you know the salt march in 1929, where Gandhiji did a salt march against the highest taxes on the salt. The British were they know the importance of salt, so they imposed high taxes on the salt and prevented Indians from taking good amount of salt. So and that time Gandhiji said, like water and air, the next most important is salt for health. So if you see in the world, God has created Almighty God has created so many things. Like what is essential, God has created it in
abundance, like you take water or air, sunlight, what is essential is abundant. Similarly, salt is very abundant. You see so many salt lakes and sea, the whole ocean is salty, and we have so many salt caves and salt land salt reserves and all. So, and if you read history, salt is very important for civilization also. Like several cities have formed where salt reserves were there and where salt was easily available, and it has affected our history so much. There were wars for salt, just for salt. There were so many wars also. So let's see how physiologically salt will affect us. So we were born in a high salt water, right? And the fetuses are 3% saline, and evolution wise they say we evolved from this ocean to land. So we have developed to conserve salt and water. We have developed Renin angiotensin aldosterone system, RAS system. Okay, so this RAS system will conserve salt. Okay, it is not reverse. Salt will not cause rise, increase in RAS system. We will come to that. And RAS is very crucial for so many conditions like renal, cardiac, and vascular physiology, as well as pathological conditions like hypertension, heart failure, and renal disease. So how this salt activates the renin angiotensin aldosterone system. So whenever there is low salt is detected by the kidney, when the renal perfusion decreases because of the low salt, it will secrete renin, and this renin will convert the angiotensin to angiotensin 1, and angiotensin 1 is converted to angiotensin 2 to the AC enzyme from the lung and kidneys. And this angiotensin will increase sympathetic activity, will increase sodium conservation, will secrete aldosterone, and it will cause vasoconstriction, as well as it secretes ADH. So it is because of the low salt this system is activated, not otherwise. So low salt causes activation of RAS, activation of secretion of aldosterone, secretion of ADH. So if you lower your salt intake, what happens? You need renin inhibitors, you need AC inhibitors, you need beta blockers, you need aldosterone inhibitors, you need vasodilators, you need so many things. Okay, the point is aldosterone not just conserves salt, it also has directly been linked with obesity, directly been linked with liver disease, non-alcoholic fatty liver disease, and it is also with obesity. Okay, it is associated with insulin resistance. It causes insulin resistance directly, and it causes dyslipidemia, and it causes hypertension. It is not salt which causes hypertension, it is RAS activation. Aldosterone causes hypertension. So literally low salt intake will lead to hypertension rather than high salt intake. High salt intake in some cases it can lead, but low salt intake definitely causes hypertension in chronic low salt intake. And aldosterone also causes fibrosis. Left ventricular hypertrophy is very well known. Aldosterone causes, and it also causes vascular fibrosis and also renal disease. It is very well known. So other side, angiotensin 2. Angiotensin 2 is also promotes RAS activity. It also causes reactive oxygen species, and it is also inflammatory and also cancer causing. Okay. So on the other hand, so this is the salt distribution in our body. So some roughly 50% is in the ECF, plasma and interstitial fluid, and 50% is in the soft tissue and bone. So this soft tissue and bone also is exchangeable to some extent. 50% of which is exchangeable salt. So once you lower your salt intake, salt from your tissues, your bones will enter into the bloodstream, and will protect you from rising RAS system to some extent. And the importance of this, another thing is local RAS activity will be there, not just systemic RAS. This systemic RAS, apart from systemic RAS, there is local production of aldosterone, angiotensin, which also causes problem. Okay, which also causes fibrosis and all. So at the other side, when you take more salt, what happens? Cardiac distension will occur and ALP will be secreted. ALPs and 18 nitric peptides and BNP also will be secreted, and C-type natriuretic peptides also will be secreted. So all this cause natriuresis. So the excess of salt will be secreted in the urine and it will be excreted out. And it counters Renin RAS system also. Okay. So So we have newer drug like medicine inhibitors. So these increase the ALP because ALP has also got anti-inflammatory and anti-cancer effects also. So ALP is. So what do you want? What do you want? Like, do you want RAS system activation or ALP? This is anti-inflammatory or an anti-cancer. So this salt homeostasis, sodium homeostasis occurs through the RAS system at one side and natriuretic peptide on the other side. Then salt, if you take excess salt, natriuretic peptide increases salt excretion, sodium excretion, and causes anti-inflammatory and anti-fibrotic effects. Whereas if you lower your salt intake, RAS system will get activated. Renin will increase, aldosterone will increase, angiotensin will increase. All these will cause inflammation, fibrosis, and all the problems of RAS system. So you have learned throughout your MBBS and all how RAS affects the system. And it will also there is increased mortality in all of the conditions. So on the other hand, there are other factors also. Like insulin resistance. When insulin levels are very high, they cause sodium retention and they inhibit the ALP signals. So that is what the problem is. So those who are salt sensitive are usually obese and overweight with high insulin levels. So these high insulin levels will cause sodium retention and that causes blood pressure to some extent. And apart from that, potassium also is important. Potassium it inhibits the RAS system, but at the same time, if it is very high, it stimulates aldosterone also. And there are other factors, ADH and magnesium, particularly magnesium. So magnesium causes vasodilation. So you should take all these together, not just sodium, because what we used to consume previously was sea salt or pink salt or rock salt. So all these had good amount of potassium, like Sir has quoted one study, potassium with salt light has shown benefit. So as a whole, salt should be taken, not a refined sodium containing 99% sodium containing salt. And renal function is also important. If your renal function is good, in a week you can increase your salt excretion by 10 times. Okay. So what is aldosterone breakthrough? So because now there are so many drugs, ACE inhibitors, ARBs, so all these are blocking the RAS system. So what is happening is, after some time, what happens when you are still continue to take low salt, the renin will become very high. Renin level will become very high and will cause the stimulation of aldosterone secretion again. So do you need another aldosterone blocker or some other intervention like renin inhibitor itself can be done. But renin inhibitors also did not show much improvement in this aldosterone breakthrough. So before going any further, I would clarify what is salt and what is sodium. So 40% of salt is usually 40% of salt is sodium. It depends upon what type of salt you are taking. It could be slightly lower if you take sea salt or pink salt. So roughly 40%, and WHO recommends less than 5 grams of salt and less than 2 grams of sodium, and AHA less than 5.7 grams and sodium less than 2.3 grams. So similarly, European Heart Association. So if you see this media, Lancet study attack by publishing study, attack by publishing study claiming low salt could kill you. So you can see that the media, what they want to show you, they want you to lower salt intake. So who controls the media and what they want. Those who control media, they also control the pharmaceutical industry and all. So what they want, do they want your health? You should decide. Okay. So this, whenever you publish a study which shows low salt intake is harmful or high salt intake is beneficial, so they will not cover. First, they will not publish it. Second, if they publish also, you will be criticized. Okay. So the bias you can clearly see. So first, coming to this European Journal of Heart Studies has also quoted. So this is a review where they have shown that world population where moderate salt intake is not associated with increased cardiovascular mortality. So moderate consumption of salt is not associated with increased cardiovascular mortality, and also the risk of cardiovascular increases when sodium exceeds more than not salt. Sodium exceeds more than 5 grams means more than 12 grams of salt. But they recommend less than 5 grams of salt. This sodium. Okay, they are confusing you between sodium and salt. They are always confusing you. Okay. So this is the data what shows. In this study, in this review article, they have shown this that between 3 to 6 grams. Between 3 to 6 grams is the lowest mortality. So that corresponds to around 8 to 15 grams. 15 grams of sodium. 8 to 15 grams. So that is the lowest mortality, and you can see the blood pressure rises. There is increase in blood pressure with increase in sodium, but that is within the range of normal. Even at 12 grams, that is almost 30 grams of salt. So another thing they looked at is the potassium intake also. So if you see the sodium intake along with potassium intake, the lower the region, the lesser the mortality. So hazard ratio is low, yellow or green areas. So you can see the even after taking more than like 10 grams, if you are taking good amount of potassium, you are not going to increase the cardiovascular mortality and all-cause mortality. Okay. So this is another study from NEJM 2016. So urinary sodium potassium excretion mortality and cardiovascular event. So this study also shows that between 3 to 6 grams is associated with lower death and cardiovascular events, and was either higher or lower estimated of intake. So they just estimated the urinary sodium. So it should be compared with the oral intake. Oral usually will higher than what the urinary excretion will be. So here you can see the red line is the WHO line. So what WHO recommends. So WHO recommends 2 grams of salt, but you can clearly see even if you are taking more than 12 grams of sodium, overall excretion, even if it is more than 12 grams of sodium, the mortality is much lower than what WHO recommends. Okay. So although moderate excretion, that is between 4 to 6 is associated with least mortality, but still what WHO recommends is far more harmful than what if you would be taking otherwise. Yes, excretion. When excretion is more, you need to have oral also more. Yes, sir. If you are taking 2 grams, you will be excreting much lesser than that. Sir. So if you are excreting 2 grams, that means you are taking more than that.
But if you go back to that, if the excretion is lesser,
Yes.
then the odds ratio increases. The risk of events is close to 2x that of normal. The same listing, excretion,
Yes, sir.
as we are going with lesser excretion.
Yes, sir.
So that means the odds ratio is also increasing.
Yes, sir.
Then the risk of events is increasing.
If you are taking less than 2 grams, definitely it is more.
This is
odds.
excretion, not intake is what I said.
Yes, sir. Excretion. When excretion is more than 2 grams, automatically oral intake will be much more than that.
No, what I'm saying is that line you have dropped the line.
Yes, sir.
That is not correct because WHO doesn't say 2 grams excretion. WHO is 2 grams intake.
Yes, sir. Of course, but the thing is,
You can't extrapolate that on this graph.
if you are excreting whatever you are taking, it will be equal to that also.
But we don't
You will be
say-
definitely excreting much lesser than what you take because you need some sodium.
Yeah, what I'm saying is we can't extrapolate that 2 grams on this graph.
Okay, sir. We'll come to that. So another study. So here they have written this is meta-analysis where they have seen the cohort studies. So they have concluded the usual salt intake, which is moderate amount. There was the number of events was stable, and then versus low usual salt intake what WHO promotes. So both high as well as low intake were associated with increased mortality in this study. So in this another epidemiological study, where they have observed urinary sodium and they compared the mortality. So in this study, the sodium intake was positively associated with life expectancy and inversely associated with mortality. So higher the sodium intake, higher the life expectancy and lower the mortality. So you can see clearly where WHO stands, where European Society of Cardiology stands. They stand where there is more mortality and lesser life expectancy. So higher the salt intake, higher the life expectancy and lower the mortality. You can compare the Japanese population. Japanese they take 15 grams, 12 to 15 grams of salt per day, even much more than that. their average intake is around 12 to 15 grams, and they are much leaner and much healthier, and their life expectancy is highest. They live for more than 100 years. You pretty well know. And another study where they have looked at the sodium and potassium intake and on-cause mortality. So they found the inflection point of sodium intake of more than 3133 mg per day. So at this inflection point, you can clearly see mortality decreases. Here it's clearly intake, sodium intake, mortality decreases, and much more even after taking more than 10 grams of sodium. 2 grams is a much lower mortality, and the sodium potassium ratio of 1.4 was associated with the lowest mortality. So even in heart failure, so in this study, they have looked into the heart failure cases, and they compared low salt restricted diet people and those who are not salt restricted for over 1 year in heart failure patients, and they have concluded like there were slightly more deaths in the heart failure patients, those who were salt restricting compared to those who were not salt restricting, but it is not statistically significant. And they have concluded there is dietary sodium reduction did not reduce clinical events. So there is no clearly there is no difference between low salt diet and high salt diet, and normal salt diet, usual salt diet in heart failure. So that was heart failure with reduced ejection fraction, and just like Sir told in patients with heart failure, preserved ejection fraction. So here higher salt intake. Restricting salt intake was associated with increased mortality. So over restricting cooking salt intake restriction was associated with worse prognosis in patients with heart failure preserved ejection fraction. Why? Because when salt is restricted, RAS will activate, and RAS system and aldosterone is the primary pathogenesis mechanism for heart failure preserved ejection fraction. You like
Heart failure
these elements are at that, please.
Heart failure preservative has nothing to do with RAS. That is
Why do you give aldosterone inhibitors in patient with heart failure preserved ejection fraction?
in heart failure preservation fraction, when ARNI has failed, then ACE has failed, MRA has failed. Except SGLT2 inhibitors, no drug has shown benefit in heart failure preservative. Even TopCat did not show reduction in mortality with MRA. It only reduced hospitalizations without a reduction in mortality. All drugs are failed because RAS does not have any role in data. This is established.
Okay, we'll come to that later also. And another study where they have looked into urinary sodium excretion, it was also with greater risk of myocardial infarction patient hypertension. So even in hypertension patients, if you are taking lower salt, those who are having higher salt intake are also with much lower events and mortality in this study. This was published in the Journal of Hypertension. So this was pretty old study where it was published in Internal Medicine Journal in 1993. So you can see clearly low salt versus normal salt. Normal salt they have taken 12 grams per day. So blood pressure there is no significant difference, almost same. Whereas uric acid is higher and insulin is higher in patients with low salt. And you can see cholesterol as well as ApoB is higher on the low salt, and HDL is much better, and ApoA1 is much better in normal salt intake. That's because the salt suppresses so many hormones. It suppresses renin system, renin-aldosterone system, it suppresses sympathetic system, it suppresses insulin, it improves insulin system. We come to that later. Next, clearly you can see like there is hyponatremia associated with increased mortality in so many conditions, MI, stroke, sepsis, hospitalization, if you take anything. And this hyponatremia prevalence has increased with the time course of adoption of low salt diet. That is very clear. So clearly when there is low sodium in the system, RAS will activate, aldosterone will increase, and sympathetic activity will cause more mortality. So compared to salt and hypertension, so salt is prohibited as well even before the data was available. So this was Times magazine in 1988 where at the time not much data was there, no meta-analysis, nothing. So during that time also salt was available. So you can understand that. So this was a Journal of Hypertension article. This is a comment on that article because I could not get the original article. So this was a comment that was published So in this meta-analysis, the risk of systemic bias produces selective copying because nobody is going to publish a study where high salt intake was associated with lower mortality or lower blood pressure. Okay, so that is the selective bias. Publication bias is there in salt. And inclusion of inadequately controlled trials with spurious condition. So this was a comment which was issued on this article. So let us come to the latest Cochrane analysis or meta-analysis by Cochrane. And here you can see the effect of low salt diet, what is high salt diet on blood pressure, then aldosterone, catecholamine, cholesterol and triglycerides. So here they have stated that the effect of sodium reduction in whites was as follows. Normal blood pressure difference was only minus 1.14 and diastolic was minus 0.01. So not much reduction with lower salt diet. And at the same time, we have concluded mean arterial blood pressure decreased by 0.4 mm in participants with normal blood pressure and mean arterial pressure decreased by 4 mm in participants with hypertension. And there is weak evidence to indicate that this little greater in blacks and Asians. Blacks and Asians had little greater effect on the blood pressure. But this was based on very weak evidence. And the effect of sodium reduction on the potential side effects on the hormones and lipid profile was consistent in all the studies. There is clear evidence of effect on the hormones, renin aldosterone system are overexpressed in low salt diet and cholesterol. Lipids are very clear. And this is the estimated population salt intake. You can see the Central Asia and Pacific Asian population, that is Koreans and Japanese, they take more salt. And you know they are lean, they are having much lower mortality, high life expectancy. So let us look into the study by Koreans. So this was a study in Korean people where they have taken sodium intake and prevalence of hypertension and coronary artery disease and stroking Koreans. So here you can see that they divide into quartiles, 4 quartiles depending on the salt intake. The highest quartile took around 9.5 grams of sodium, which corresponds to around 22 grams of salt, and lowest 2.3, that is WHO recommended level. So clearly you can see hypertension incidence, number of the prevalence of hypertension was much lower in those with higher salt intake. You can see coronary artery disease incidence much lower with significant ANOVA statistical value, and stroke incidence was also much lower, and you can see obesity incidence was also much lower, and they were more employed, they were receiving less subsidy because they were more active and did not need subsidy, they were more educated, and they were having less dyslipidemia, and diabetes incidence was also much, 50% lower. Those who take higher salt intake had 50% lower incidence of diabetes. And exercise also, they were more active also. So you know Japanese population, they are workaholic, they do regular, so much work. They work for so much time, like 18 hours, 15 hours. So that's because of the higher salt intake probably. Yes, salt sensitivity is different because of the salt sensitivity, as I said earlier, is because of the insulin resistance. Insulin, when it is high, it will retain salt. So that time, and when they are taking low potassium, that time it will rise the blood pressure. Otherwise, sodium will in fact lower blood pressure, lower your heart rate, you know. And this is the INTER-SALT study which Sir has also quoted. So if you look at the results, across 48 centers, sodium was significantly related to the slope of blood pressure with age, but not median blood pressure or prevalence of high blood pressure. So it was not associated, not compared to the previous prevalence of, comparable with the prevalence of blood pressure. And BMI and alcohol intake was strongly associated with the relation of blood pressure, not salt, not sodium. Okay, so here you can see INTER-SALT study. There were, if you take this last 4 populations, which were tribal populations, their sodium intake was much lower, and they were isolated populations. They were hunter-gatherer tribes. So if you take into those people in consideration, the slope was higher salt intake causing high. But if you exclude them and you take regular population, the normal moderate population, higher salt intake was associated with lower. The dashed line you can see, higher population, higher salt intake was associated with much lower blood pressure. The slope is sloping down. So they add such populations where it affects the data. So this was another study where they have divided three groups, A, B, and C. So in the B group is a control, and A and C group were on angiotensin blockers and ARB blockers, angiotensin AC inhibitors and ARB. A group and C group, you can see with sodium increase in sodium intake, there was slight increase in blood pressure. But those who are not on AC inhibitors and ARBs, blood pressure remained the same. If you see the B line is same only. B line is straight. Whereas A and C line where AC inhibitor ARBs are there, it has slightly increased. So if you block the regulations, then you will become salt diagonal. So coming to salt versus sugar. Salt is actually opposite of what sugar does. So usually salt takes most of the blame what sugar does. So that is why you need to see what when compared to when compared to sugar what salt does. Low salt intake is also increased insulin resistance in healthy subjects. In this study also there was increase in insulin resistance with low salt diet. So here you can see those population who were taking low salt diet and high salt diet. This was after 1 week of high salt diet and low salt diet population. Okay. In the population you can see BMI is comparable, slightly higher on the high salt diet. Despite higher BMI, they are having and slightly increased mean arterial blood pressure. You can see significant reduction in aldosterone, 21 to 3, 3.4, and TR is also suppressed, angiotensin is suppressed, and you can see epinephrine and norepinephrine are suppressed, and HOMA-AR, if you see, HOMA-AR is much lower in those who are on high salt diet compared to low salt diet. So this is another study which was done in rats. So here you can see low salt diet is also good. Modulates insulin signaling and INS activity and JNK and IR phosphorylation fat tissue. So that is how the salt directly affects the insulin receptors also and causes insulin resistance. So in this study, they have looked into the salt supplementation and glucose tolerance. So after salt supplementation, those who are insulin salt sensitive, there was reduction in glucose tolerance. So sugars are much better after giving the salt. And so other group was salt resistant, so they did not have much benefit. So coming to uric acid, those who are on high salt diet, uric acid comes down. So here you can see those who are on moderate to high salt intervention compared to low salt intervention, even in both the groups, like those who are normal hypertension and normal tendency as well as hypertensive patients, you can clearly see uric acid comes down after higher salt intake. So you can see three groups, normal tendency, hypertensive combined, and higher the salt intake, higher lower the uric acid. So uric acid, you know, sugar, particularly fructose causes rise in uric acid. So one side salt increases, reduces uric acid, sugar increases uric acid. So what the uric acid does? Uric acid it affects the mitochondria, it produces reactive oxygen species and affects the mitochondria and it causes metabolic syndrome. And in this study, there was suggested that it is rather consequence of metabolic syndrome. Uric acid reduces fatty liver. It is rather than a consequence, it is the cause. So, coming to other studies where they have given in rats they have given low salt versus high salt. What has happened? You can see those who are high salt diet, their food intake was higher. Despite higher food intake, their body weight was lower. That's because of the higher metabolism, because of the higher UCP expression in them. So this is another study where they have seen that in particular population, Maori population, where there was higher salt intake in winter seasons, like 30 to 40 grams of salt they used to take in winter. So they wanted to study why they take and is there any advantage. So in this study they have taken in winter months they have given up to 60 grams of salt and they have looked into the metabolism effects. Like the basal metabolism has increased to 36 to 44.5. So it raises the metabolism. Like in the previous rat study, higher salt intake is associated with increased metabolism. And when they increase the salt intake more than 60 grams and when they gave it for more than 5 days, then only blood pressure and other effects were there. and that too will subsequently clearly it affects the plasma total cholesterol as well as LDL cholesterol. It raises and makes more atherogenic profile. So coming to salt and bone. So in this study, in this review article, the authors have claimed that the salt, the higher salt intake associated with higher calcium excretion is probably because of it is compensated by the higher calcium absorption also. There is higher calcium absorption and higher calcium excretion. So that is why it does not cause osteoporosis. Whereas sugar causes osteoporosis by multiple mechanisms. So this is a Nature Journal article. So here dietary sodium intake and osteoporosis they have compared. So recent hyponatremia and chronic hyponatremia also higher odds ratio, almost highest odds ratio for osteoporosis. Compared to what other conditions, it is much higher. So there are a lot of other benefits like this old article published in Pediatric Nephrology with a nephrologist, influence of sodium on growth in infancy. So those infants who were salt losing, who were having lesser salt intake, they were having effects on growth also. They were having much lower growth of the infancy, and also higher salt intake after substituting higher salt intake in their diet. There were more growth was much better. So very interesting article you can go through. So and what about gestation? If you restrict gestational sodium intake, pregnancy, what will happen? So pregnancy, there are a lot of 3% saline surrounding the fetus. So if you lower salt intake, that salinity will get affected, and RAS will get activated. And once RAS is activated, the fetus will get retarded, and fetal growth is affected. So in this study, they have concluded lower salt intake results in lower birth rate, lower growth of the fetus, and all. So very interestingly, like this book I was reading recently, Body Electric. So here, in this study, there were a lot of experiments in this book where they were seeing into the regenerative capacity of the animals. So salamanders, they can regenerate whole limb, whereas we humans, we don't regenerate our whole limb. So what could be the difference? Why they get that thing? So finally, they conclude that it is because of the electrical system. The whole electrical system and nervous activity which causes the development, regeneration of the limb. And even humans also, beyond this line, if young humans, if we get amputation beyond this line, we can regenerate the finger. There is limited regenerative capacity in ours. So this, the salamanders which have the highest regenerative capacity in vertebrates, so what the difference is, the skin of their skin is more saline, more salty, and their neural activity is much more higher. So that is why there is more regeneration. Even in embryogenesis, the electrical activity is which controls organogenesis and all the things. We can go through various embryogenesis and all. Is there any disease model where the sodium affects the condition? So cystic fibrosis where CFTR gene is affected, and there is lower secretion of sodium into the inner side of the body, that is in the bronchus, in the mucous membranes, in the intestine, whereas higher salt is excreted in the skin. So there is overall sodium loss through the skin, and there is much lower sodium in the mucous membranes and all. So there you can see so many problems, from sinusitis to bronchitis to pancreatitis and nephropathy, osteoporosis, meconium in the newborn, and airway obstructions, so many things. So infertility. So all this will, this is what happens when you over-restrict sodium. And does it affect? Does it help reduce the condition? Yes. Hypertonic saline was significantly associated with higher FVC and FEV1 in these those who receive hypertonic saline. It is very inexpensive, and you can improve the condition of cystic fibrosis. And if you take like pharmacological model, like if you take some kind of medicine which cause low sodium, so thiazide diabetes, they cause metabolic syndrome. How do they cause? When sodium is low, it will cause RAS activation, aldosterone causes insulin resistance, metabolic syndrome, So that is how it happens. So there are hyperglycemia and hyperuricemia. So coming to sodium, Sir said sodium causes craving. So sodium does not cause craving. It is the carbohydrate which you take along with sodium causes craving. So in this study, this is the endocrinology textbook, neuroendocrinology part. Protein addition, dehydration is anorexia. You can clearly see addition of 2.5% sodium chloride to drinking water causes marked reduced food intake by 80%, almost 80%. So I call it a poor man's GLP-1. So don't deprive poor people from sodium. In my OP, I see so many patients who restrict their salt intake and come with insulin resistance, come with so many cravings because of low salt intake. You know. So the salt cravings are perceived as hunger in these people. Most of us, we perceive hunger, most of the time it is because of salt craving. So you can remain, you can fast for a very long time if you take salt and water. If you just take salt and water, you can, I have done 60-hour fast. Not to boost, but I want to tell you that it is possible. You can just take salt and water, you can fast for so many days. Up to 7 days also you can fast. So there are other culinary benefits. It improves the flavor of the food and it increases sweetness of the food and reduces the sourness and bitterness of the food. So adding a bit of salt to sweet, reduce the overall sweet intake also you can reduce. So it is anti-sugar also. And it is 2.5% salt, which causes fermentation, which causes lactobacillus fermentation. If you don't keep food in 2.5% salt solution, it will ferment into alcohol, which we don't take. So if you want the food to right ferment, you should add sodium of at least 2.5% and much more than that. Salt is the greatest preservative throughout the history, And also athletic benefits, those who take salt before performance, they act very swiftly and very explosively, they are more alert and less fatigue after the exercise. Other possible benefits like in spiritual things in Sufism and in things, salt is considered a positive energy and it reduces the negative energy. And in some of the GERD patients, those who are on low salt diet, once they moderate salt intake, they take GERD goes like after so many years of suffering, after they take normal salt intake, the GERD is gone. And in short stature, achondroplasia, one of the common bone condition causing achondroplasia, short stature, achondroplasia. So there, phosphatidylate is a novel ALP, recombinant ALP analog, where it has shown to increase the height by 10 centimeters, 5 to 10 centimeters. So you know how ALP comes. You take higher salt, ALP naturally comes. You need not take from recombinant. So another molecule you require if you take less salt. And DHAs, I suppose this is not, I could not find any literature on this, but because all the benefits I have seen, like the effects on bone, the effects on fertility, and the effect of longevity, and all the benefits, same benefits are there with DHAs also, and there is no sugar in harmful for this. So DHAs could be possible coming from high salt intake, moderate to high salt intake. So I'm planning to do study on this, inshallah. There are, not everyone should take low salt, moderate salt intake. So there are conditions where you require high salt intake, like those who have a low carbohydrate diet. When insulin levels are lower, you are not retaining sodium, and sodium is lost in urine. You need higher salt. And similarly, ketones. Keto diet also, you need much higher salt intake, more than 2 tablespoons per day at least. And when you are fasting also, if you take having good amount of salt, you are having less cravings, you can do much better fasting. And when you are taking higher tea and coffee, you need to take higher salt. And athletes, marathon runners, 28 years, pregnancy, they have higher salt requirements. And presently, all of us are taking RO water. So RO water is not having dissolved salts. So they will drain out your salts. So you need to take some amount of higher salt intake when you are taking RO water. So finally, before concluding, there are different salts. The packaged salt with iodine is also important because iodine deficiency is much common. And also pink salt, which has so many minerals, but there is less of iodine, so that is also important. So I recommend combine the salts. And previously we used to have sea salt, which had approximately the right ratio of potassium and magnesium in the salt. And similarly, black salt is rich in sulfur. So sulfur is good for detoxification and good for harm-prone action of hormones like DHEA, DHEAS. DHEAS is much longer half-life because of the sulfur action. So finally, conclude, low salt intake is harmful. Definitely, as shown in so many studies, low salt intake is harmful definitely, and moderate salt intake, moderate what I consider is more than 8.5 to 15 grams is beneficial, and to err on the higher side is much better than taking on the lower side. And your taste is the best judge. When you are having low salt, your the taste of salty food will increase. So you like salty food at the time where you are need more salt. So taste is the best judge to take salt. And good amount of potassium and magnesium from vegetables, and low carbohydrate diet which checks the insulin in the check, which lower the insulin levels, is required for the high salt intake to be considered safe. So those Koreans and Japanese, they take much lower carbohydrates, they take much higher potassium and magnesium. So they can take much higher salt intake, like 20 grams, 30 grams they can take. Thank you. I thank Dave for giving this opportunity, and thank Dr. Khalid Saab for taking this topic along with me, and I thank Almighty Allah for giving me this knowledge, and I thank Rasulullah Sallallahu Alaihi Wasallam for giving me this guiding through this knowledge, and I thank all of you for patiently listening. I'm happy and grateful that you are there on this Sunday, taking so much time. Thank you. Thank you very much.
Jazakallah khair, Dr. Mujib. बहुत intense debate है, हम लोग लेके चलेंगे. Reason being, हमारे इसका वक्त थोड़ा, so we will have time for only 3 questions. हाँ.
So, as Dr. Mikhal here, I'm a cancer specialist. I just wanted to make a few points for you today. As you know, we are dealing with comorbidities today. I just wanted a comment from both the wonderful speakers who gave even great in-depth, deep knowledge into this. But if you come to the overall picture, today at the end of the day, we are practicing medicine, especially multidisciplinary management. My point is very simple. I just like your comment. See, all this, especially the salt, sodium chloride, the sugar, we in the field of cancer, and you know, most of our patients, 80% are all comorbid. We deal with patients who have diabetes, hypertension, who have kidney problem, who have dialysis. 75 to 80% of our patients are comorbid. And I think Dr. Mujib, you also see a lot of our patients, and even from cardiologists. So it's all about moderation. At the end of the day, it's all about moderation. So with the complex challenges of managing 55-year-old plus patients with cancer and comorbidities, which you have talked about, what do you think is the moderation line? One thing we both haven't talked about is moderation and lifestyle, stress, and exercise. Because studies have shown with all these comorbidities, when you have complex diseases, 40% of the disease profile improves with 20 to 30% lifestyle management, which includes food, stress, exercise, which kind of detoxifies and burns out all the things we talked about. So what is your comment on moderation in complex disease management, especially in my case where the cancer patient comes, 60-70% are all comorbid.
Sir, definitely, thank you for that question. See, as I told you, as far as salt is concerned with heart disease, it's all about moderation. No salt is bad. Whatever data which you have also shown is basically showing you that when you are taking no salt, as bad. Because if there is no sodium, that will activate the Rask acid. But when you take salt in moderation, it does not activate the Rask acid. When you take a restricted salt in a patient with heart failure, it prevents activation of the Rask acid. Now, if you are talking about patients with multiple comorbidities, like for example, if you had a patient who was having cancer with on-treatment chemotherapy with a normal LV function, I would not restrict salt in his diet. I would give him a moderate salt diet. Of course, not high salt, that is definitely out of my textbook. Moderate salt, I'm fine. But if the same patient has an EF of 20%, 25%, I will restrict salt to less than 1.5 grams in that patient also. Because for him, giving him a moderate salt diet is going to land him in heart failure and his repeated hospitalizations will increase. Now, if you look at the sodium HF trial, it showed that there was no significant difference in ambulatory patients. In ambulatory patients, if we reduce the sodium to less than 1.5 grams, those patients versus keeping it between 2.3 to 4.6 grams of sodium, there was not much difference. But in hospitalized patients, if you bring the sodium down to less than 1.5 grams, there is a definite benefit provided your serum sodium concentration remains within normal limits. If your patient is having hyponatremia and you are restricting his salt, then you are going to worsen outcomes. So it is a multidisciplinary approach. We have to look at his renal function, we have to look at his electrolytes, we have to look at his whether he is ambulatory heart failure, whether he is hospitalized heart failure. Depending on that, we take a decision. For most of the ambulatory heart failure patients in India, like I told you, even a moderate sodium restriction around 2.2 to 3 grams is fine. But if your patient is a refractory heart failure or ambulatory class 4 NYHA heart failure, then you have to restrict sodium for those people, provided the serum sodium concentration is normal. If you are restricting sodium so much that it is causing hyponatremia in them, then as Dr. Mujib rightly pointed out, it will activate the Rask cascade, which becomes detrimental in heart failure with reduced EF. So we have to look at multiple, because we are also going to be giving them mineralocorticoid antagonists like spironolactone, which will again cause hyponatremia. So if I restrict the salt to 1 gram and then I give aldactone and the patient comes with a sodium of 128, that is worse than somebody for whom I am giving a moderate intensity salt with aldactone and the sodium is maintained around 135. So it is a multidisciplinary approach. And yes, as you rightly said, lifestyle modification, exercise, all of this does play an important role.
Yes, sir.
Like I said, because there is the problem is we are dealing with such complexities more and more because now, as you rightly said, chemotherapy poses a greater challenge when you have to be careful about the dose calculation, toxicity, side effects, and immunotherapy is coming big time. Immunotherapy is coming big time. So one has to be very careful about the interplay of all these moving parts. Immune system, age factor, chemotherapy protocols, toxicity. Then you have your comorbidities, which just makes it more complex because you don't know, you can't compromise either way. I think if you compromise, you're losing something. If you compromise chemotherapy, you're losing on the outcome of it. See, ultimately, we all want to do the best for the patients. We want the best for them. We want the best for malaria. We want the best for cancer control. Where is the challenge? Where do we, kind of find the moderation? There's so many factors.
When there are so many comorbidities, we had take each and every factor into account. And we should start with moderation. Like when patient, we should never lower the salt within those who are having comorbidities. So then, if you lower the salt intake in those who are having comorbidities, multiple comorbidities, like except CKD comorbidities, we need to restrict sodium intake. Apart from that, in heart failure also to some extent we need to restrict, but we should not restrict too much in heart failure also. So because if you restrict the sodium intake, again Rask will activate, again the whole cascade will happen and morbidity increases, and finally it culminates with hyponatremia. So when usually we should recommend moderate intake. Moderate in the sense 10 to 15 grams of sodium salt. So what I have shown in so many studies is like what WHO is much lower and more mortality. So those who are having comorbidities, first you should look into the factor of insulin resistance. If patient is having insulin resistance, they are going to maintain sodium. But at the same time, if you restrict sodium, insulin resistance also will increase, and dyslipidemia also will increase. So you should start with moderation and slowly you should ask them to reduce their carbohydrate intake, which reduce the insulin resistance, and then you should then you can after 1 week or 8 days, depending on their situation and their blood pressure and all the factors, taking into all the factors, you can slowly come to the higher moderation level, so that the RAS system is suppressed and so that they get all the benefits of moderate taking salt.
Last question is,
I have questions to both these people. Sir, your premise starting from history, saying that historically we have been taking salt or evolved from salt and all. But historically speaking, people were more physically active when compared to today. So how do you correlate with that? And moving on that, most of the talk was on salt and diet, as sir also pointed out. How much physical activity should be increased to compensate for the salt intake? That is one question. And sir, you pointed out many Japanese studies. So, normal Japanese person, how much he walks is 2 to 3 times more than an Indian person who walks on a daily basis. And they are coastal people. And you consider coastal people, their atmosphere and their cultural habits, their culinary habits is very different from cities. Also, sir, as you pointed out, guidance from European Society or American Heart Association or WHO. Most of the studies are based on Eurasian population, not an Indian population. So, how much do we consider the genetic predisposition and epigenetics when extrapolating those studies are both guidelines to Indian population?
see, very rightly said, is a very valid point, because in fact there was a study which I had shown also, Dr. Majid showed the pure study. So see, the pure study was done in a predominantly Japanese population. They showed that even having a high salt diet does not affect the incidence of heart failure and other problems. The reason there is because, as you said, they consume a very high potassium and magnesium diet. Now, if you are taking a good potassium diet, you take as much salt as you want, it doesn't matter, because potassium takes care of the sodium. An average Indian diet does not contain that much of potassium. And unless they have done a study also when they, in fact, that same European journal said that there is inadequate evidence to suggest a low sodium diet. If you read through the entire article, they have mentioned a paragraph over there on just on this point, saying that increasing sodium can be done safely, provided you concomitantly increase the potassium intake as well. But majority of the studies which have been tried, the populations have not been able to put up with that much of intake of potassium, because our gut is not used to that much of intake of potassium. In coastal areas, Japanese populations, they have totally different epidemiology. And yes, we need our own data. That is the reason why we need our own Indian data. We need our if you see another slide which presented, Asians consume the maximum amount of salt compared to Americans and Europeans. So as such, our bodies are attuned to a little higher amount of salt. That's why probably in majority of Indians, I feel a moderate salt diet, like as recommended in all of it, defined as 2 teaspoons of salt, that is 2.3 to 4.6 grams, is fine. Unless somebody is in heart failure. If it is a heart failure, decompensated heart failure, I will restrict, because I really don't understand how restricting salt activates RAS unless it causes hyponatremia, because the body's homeostatic mechanism is strong enough to prevent RAS activation within that limit. Of course, if we are restricting it so much that it's causing hyponatremia, yes, it will activate RAS. But the whole premise of restricting salt is taking increased salt increases total body water, which stimulates your glomerulus, which stimulates RAS and activates RAS. So, in heart failure, that's how it works, to the best of my understanding. But yes, so and yes, as far as activity is concerned, heart failure in cardiac patients, what we recommend is 30 minutes of activity 3 times a week, minimum. But again, as with anything, we say start slow. You do 10 minutes per day until you can increase it to as much as you tolerate it. When you can't tolerate it, you do 30 minutes 3 times a week minimum. Best is every day. That is the cardiac recommendation.
Depends on the excretion of salt for skin.
Excretion salt to skin.
Skin sweat. You have to take more.
Those who, yes, of course, those who use salt to skin sweating, they need to compensate regarding the diet. Those who are footballers, like, use like 5 to 8 liters of sweat, which corresponds to around 5 to 6 grams of sodium per hour. So they need to take extra dose amount apart from the daily intake. So coming to the question, which Sarah is asking about the sodium intake, older people, where they were much more active. Historically, they were taking more salt, but they were much more active. But they were not so much active that they used to use salt. They used to take salt in preserved food, like with potassium and with magnesium, with the vegetables and all. So with pickling and all, you take some of the potassium and magnesium, and that protects from the higher salt intake causing any harm. So and they were active but not there is no quantification, but those compared to if you take the Japanese population now, they are active in the sense they do desk job only. Most of the Japanese are workaholic, they do the desk job only. Particularly in Tokyo, if you take urban areas, their apartments are very, very small and they work in the small restricted areas, and the Japanese people, they stay in the office only, they don't go to home. They used to switch off the light. The government has come up with switch off the lights of the office to send them home. So they do the desk job only, but still they take higher salt intake. So higher salt intake has advantages of suppressing so many hormones there in aldosterone, similarly activity. It makes you calmer, it makes you much more efficient, more active. Whereas if you lower the salt intake, similarly activity goes up, your anxiety goes come up, you're more anxious, more you're much more affected with lower salt intake. Lower salt intake is definitely harmful, which I want to promote. Moderate to higher salt intake is much better. Or you take good amount of potassium and magnesium.
Just one last point. I know it's getting time for us, sir. But there are so many youngsters. Can you give me the mic, please? I am constitution and professor head of committee in Assam Hospital. So I would just like to tell all the young kids over here, because the take-home messages must be very clear. Whatever we, at our stage, up to 35 years of academics, we can draw lines wherever we want. But youngsters should take-home messages which are very clear. Please remember that Indians do not, the way we use salt, we don't sprinkle salt. We knead it into our food. You know that? So these yardsticks of, let it be the Japanese, any of the European, their way of using salt is very different from our way. The kebab you take, the biryani, the dal you take, it is all full of tadka and all that stuff, which increases the salt intake and which is harmful to some extent. In pregnancy, like Dr. Muket and Dr. Saket gave very good points, but just to tell, in pregnancy, like in early pregnancy, many women have hyperemesis. They keep losing salt, which is harmful for the growing fetus. So invariably we give a saline infusion, we ask them to take soups and all those things and keep themselves hydrated. Short, frequent meals we will get. But if they have a history of hypertension in the family, and if they are little elderly, some girls are there like that, so we always tell them that please maintain your salt intake to 2 to 3 grams per day. Don't go beyond that, because lest you become hypertensive. And a girl who has already become hypertensive, we cannot tell her don't take salt. We just say restrict and drink plenty of water. Drinking water alone is extremely important for good health, which most of our own students don't do. Half the time, how many of you drink water? You don't drink water, just drink water. It's a nyamat of God. It has so many electrolytes. your parents, your grandparents, all went on. And one more problem with our youngsters. I'm a graduate of Madras Medical. I'm telling you, those days we had cardiology department on the 15th floor. And our superintendent will literally, bang us if he sees any of us even taking a lift from the 6th floor. We had to climb 15 floors to attend the cardiology posting. Whereas now I see my own students, from the first floor to second floor, they want a lift. I sometimes wonder what will they become tomorrow. So these things are important. Please keep in mind, just as in life, Allah Ta'ala has told, our Paramount has told, moderation, let it be anything, is important for us. Okay, thank you, sir.
Madam. For those of you who don't know, Madam is a renowned obstetrician. She is Secretary of Gynecology and Obstetrics at Asra Hospital. Thank you, ma'am, for those words. Because of paucity of time, we are not able to have session of Talha. Sorry, we don't take any more questions because Asra ka ho gaya already. So, questions we can have it after the Asra. As Sadiq bhai told, unless I heart goes bad, till then I'll have more than moderate amount of salts. If I have insulin resistance, then I go to Mujib bhai. If I develop, some people drinking potable water in pots and copper kettles, so that some amount of electrolytes get added. Avoiding French fries and tali with namak, rose and jam with namak, anything. As long as we don't have any issues, we can have. Otherwise, very contradicting views both of them had. This was more intense than the Mehdi Nasr debate what we see. Jazakallah for those kind words, ma'am. And then we would like to conclude this. Before this, I would like to call upon Dr. Professor Masood Sahab for felicitating Dr. Mujib Afzal Sahab. Dr. Professor Masood Sahab, as you all know, is CEO of BB Cancer Hospital. Along with him, I would like to call Rikhar, the radiation oncologist, onto the stage. Dr. Rikhar, please. Dr. Mujib, onto the stage, please. Dr. Mujib, onto the stage. Jazakallah khair, sir. Thank you. Thank you, sir. Now I would request Dr. Aisha Madam onto the stage to kindly felicitate Dr. Sadiq Azam. You who all don't know Sadiq bhai is my senior for Kims and he is very kind-hearted as well as whenever we send a case to him, we have a full report of that. Thank you, sir.
Osama is underplaying his own kind-heartedness in this gem of a person.
Thank you, Sadiq bhai. Thank you.
Also, incidentally, my son.
Yes, we know that part. Okay, but I was that.
All the felicitations, this is probably most special.
MashaAllah. Jazakallah khair, madam. Jazakallah khair, sir. Before we conclude, I would like to call Dr. Talha Fayazuddin for dua. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار ربنا ظلمنا أنفسنا وإن لم تغفر لنا وترحمنا لنكن من الخاسرين عما يصفون والسلام على المرسلين والحمد لله رب العالمين. हम लोग सब इंशाल्लाह पास की मस्जिद में जो है 5:15 को नमाज है